I'll go ahead and let Dr. Tarantolo introduce Dr. Kim.
Good morning. I'm taking over for Bernie, and I'll introduce the next few speakers. It's my pleasure to introduce Dr. George Kim. He's been a long-term friend to Nebraska Oncology Society. In fact, he's presented at every meeting. I was a very close friend to Dr. Pete Townley, who the conference is named after. And for that, we're truly indebted to Dr. Kim. We've also had the good fortune of watching his children grow up with the College World Series events. It's from young people to young adults. George is a associate professor at George Washington University in the Department of Hematology Oncology. He's an international expert in GI malignancies, and he's presented every year. In some years, the improvements in GI oncology has been somewhat low, but I think this year you'll see some exciting, he'll presenting some exciting results today. So I'd like to thank you for your dedication to Nebraska Oncology Society and agreeing to present today. Thank you for coming.
Thank you. Thank you. And it's always great to participate in this meeting. And I'm so grateful that you invite me. So, and it's great to see you, and I think Ralph's on the call as well, just to see those names. And someday we'll get back to being in person. So kind of an old man question. I'm just using my computer. Is that right? Okay. So again, thank you for the invitation. I'll get you guys out of here soon. I know that I believe I'm the last speaker. So let's go ahead and get started. This year at ASCO 2022, for colorectal cancer, we did have a plenary presentation looking at EGFR inhibition. There was also some really exciting data on rectal cancer. We're going to talk about that. We just heard from our colleagues at Natera about the ctDNA, and there were some very good studies there. We'll talk a little bit about pancreas cancer, gastric cancer, bile duct cancer, and neuroendocrine tumors. Now, one comment about the GI section was there were very few American presentations, US studies. There was the one with the neuroendocrine tumors and then the rectal cancers, but the rest were really kind of European and Asia. And the reason for that is they use a lot of EGFR inhibitors there. Can you guys see the pointer?
Yes.
Yeah. Okay. So let's go into colorectal cancer. Now, I was asked to make some questions or come up with some questions. So this is what I came up with. In metastatic colorectal cancer, patients benefit from first-line EGFR inhibition. Which patients? So the possible responses are right-sided, left-sided, BRAF mutated, or KRAS mutated. So we'll come to this answer later on, but that's the question. And then I'm going to go to the next question. Treatment paradigm for rectal cancer, locally advanced rectal cancer, will change by eliminating the radiation, eliminating the chemotherapy, eliminating surgery, or all the above. Okay, so we'll come to that answer hopefully after the presentation. And then finally, which of the following are FGFR2 inhibitors or FGFR inhibitors? And these are your choices. Okay, so those are the questions, and I will give you the answers as we go through the presentation. Okay, so the plenary presentation was looking at, again, panitumumab versus bevacizumab. So this is an analysis that we've done numerous times: anti-EGFR inhibition, anti-VEGF inhibition, or VEGF inhibition, and backbone chemotherapy of FOLFOX. Okay, obviously this has to be in all RAS wild-type patients, and we're looking at sidedness. So this was a Japanese study, which is a little surprising, and I'll get to why in a few minutes here. Okay, so again, anti-EGFR versus anti-VEGF. We've done these trials. CLGB 80405 was the US trial, showed a median survival of about 30 months. Hazard ratio was not statistically significant. The FIRE3 trial was the European approach using cetuximab EGFR inhibition with irinotecan-based chemotherapy, and they suggested a benefit here. So what we did learn from these trials was that there was a difference in sidedness, and the left-sided patients did better than the right side And that was shown here by Dr. Manook all the way back in 2016 now. Man, time is just flying. This is 2016, but there was a difference in median survival of about 20 months. So that was important. And this was a post-hoc analysis, and no one had done a prospective trial. So that's how this Japanese study got to the podium, okay? Because 20 months is a big difference. All right, so this is the actual trial. Patients with wild-type metastatic colorectal cancer, unresectable, ECOG 0 to 1. They had to be evaluable. Standard type of eligibility. And again, the randomization 1-to-1, panitumumab versus bevacizumab with backbone chemotherapy consisting of oxaliplatin FOLFOX. Primary endpoint, left-sided. Okay, so that's what makes this analysis so unique. And if significant, go on and look at the overall population. Okay, typical other endpoints. We'll talk a little bit about this depth of response in a few minutes. Okay, so this was the outcome, right to the punchline or the summary. Survival here in the blue was improved with panitumumab in left-sided patients. Okay, and I'm just going to highlight what goes on in the clinic. Patients are treated here to about 10 months because the oxaliplatin neuropathy kicks in. They sometimes get to 12. I'm sorry, 6 months because the treatments are every 2 weeks. So they get to 10 to 12 cycles. And so this is where the curves really are kind of together, but then they separate out here. And I'll try to explain that in a few minutes. But at the end of the day, there was a delta of about 3.6 months here in terms of survival, hazard ratio 0.82 that was statistically significant. So in frontline treatment of left-sided colon cancer patients, in this analysis, panitumumab was superior, okay? So again, the primary endpoint was the left side, and if that was positive, which it was, then they looked at the overall population, and here again, you see a difference. You see a hazard ratio of 0.84, and again, statistically significant. So again, this suggests that panitumumab is superior to bevacizumab in this analysis, okay? So that's what we see. All right, let's dive a little deeper into the data, okay? Which group benefits from panitumumab? Certainly age, gender, and I think this is important because, you know, and I'll summarize this later, but when you think about what you're doing, you're giving first-line chemotherapy to patients who have to wear a pump, who have neuropathy, and now you're going to introduce a acneiform rash. So this is a lot for patients to take on, especially older patients. And so again, there is more men, and they do benefit. And I wonder whether there is some gender differences here in terms of tolerating the treatment. ECOG status, number of organs, liver metastases, and then primary resection. In this analysis, there was a benefit here with panitumumab. We're going to talk about that later. Okay. And then in the overall survival group, very similar trends, again, favoring the panitumumab arm. All right. Okay, progression-free survival, whether it was left-sided or overall population, we've seen this over and over again. The curves overlap, they don't separate. And again, this gets back to what I was saying. This is during the treatment, and is there really an impact during the treatment, or is it seen later? These are the responses. So left-sided response in the panitumumab arm, 80% versus 68, a delta of 11. So that's important. That's important, obviously, for those patients that you may think about undergoing resection, and that's shown down here, R0 resection. Arguably, this is patients with liver or lung metastases, and 18% versus 11%. So that's clinically meaningful, okay? Duration of response, 13 months, 11.2 months. Okay. Depth of response. So this is an endpoint that people have tried to develop, mainly the European investigators. And what this shows is that panitumumab creates a greater depth of response here in the blue, obviously extending beyond the green, the bevacizumab. And if you measure this -60 roughly and -43, there's a greater tumor reduction, and I'll show you in a minute why that's important. And then in the overall population, there still is this difference. panitumumab plus FOLFOX creating more of a response. Okay. Adverse events, as you would expect, majority of patients had adverse events. Grade 3, a lot of this is probably the neuropathy. But as we know, with EGFR inhibition, you do get a good amount of skin toxicity. And this is the oxaliplatin contribution to toxicity. But overall, as expected. And again, I'll show you, this is why I think panitumumab as frontline therapy can be challenging. Okay. Hypomagnesemia is another consideration. Not a lot of side effects listed with the bevacizumab. From a day-to-day perspective, that doesn't typically happen. So that's why patients seem to tolerate that from a day-to-day perspective. So this is what I said a few minutes ago. When you look at the treatments that were given beyond first line, so again, the curves don't separate when the patients are being treated with the first line, but as you get out into these other lines, something is occurring. Okay. Now the good news is they're balanced. They're about 80% of patients go on to second line therapy, 60% third line therapy, and 40%. I think these are high numbers, but that's progress, I think, in the treatment of colon cancer. Now, if you were on an EGFR inhibitor, you went to a VEGF inhibitor. If you were on a VEGF inhibitor, you also went to a VEGF inhibitor, which is treatment beyond progression, which we've adopted, especially here in the United States. You also could have gone on to an EGFR inhibitor, and that would have been probably with irinotecan. And these are good regimens. So the point here is, and this has been seen over and over again in FIRE3 and 80405, what are the second line regimens, and are they more active? And does that contribute to why those curves separate later on? Okay. In the right side of patients, what I showed you earlier, we know that they don't benefit from EGFR inhibition, even if you're RAS wild type. So again, the bevacizumab does seem to benefit them more, and that's how we treat patients with right-sided tumors. Okay, and then finally, oh, there's a slide missing. All right, there was a slide missing for depth of control and the amount of tumor response, and maybe later. But okay, so the conclusion from the Paradigm 3 trial is that there's superiority in first-line treatment with panitumumab versus bevacizumab with the chemotherapy backbone of FOLFOX in left-sided tumors and overall. Okay, left-sided tumors had about a 3.6-month benefit, and that's important. The PFS doesn't change, and have to consider other lines of therapy. Okay, so here the summary is this should be considered for first-line treatment. Now, why don't we adopt this in the United States, or how will you adopt this in the United States? These are all the trials that have been done. This is the FIRE3 trial, which I talked about earlier, using FOLFIRI. And then the primary endpoint was response rate, which was improved, was not statistically significant. This is 80405. This was dealer's choice. FOLFOX was used in 73% of the patients. This is where we learned about left versus right. And again, the overall survival was the primary endpoint, and that was not reached. Again, more data supporting left-sided tumors, RAS wild type being treated, overall survival benefit, PFS benefit, and response. Okay. Why do we know this? Why is it left versus right? The right-sided tumors have more negative prognostic factors, BRAF mutation. They do tend to be MSI high, though. Hypermethylation, other factors that contribute to the poor prognosis. And over here on the left side, there's a more EGFR amplification. So again, it's more favorable, and these patients tend to benefit from EGFR inhibition, as shown by this panitumumab trial. Okay. Oh, this is what I'm going to show you. So depth of response. So I showed you this earlier, and I thought this is kind of naive, but I think what they're trying to say is, obviously, if you shrink the tumors in the very beginning the most, and again, here we're showing shrinkage of about 60%, that eventually the tumors are going to grow with progression. But then you come in with your second line therapy, and this line's going to dip back down. So I thought this was a little bit odd. Maybe this just pertains to first line. But these lines are going to dip back down. They're going to dip back down. And that's what's going to affect this lethal tumor load or survival. So again, I keep saying this, that the second line third line therapies are important. And certainly this paradigm is interesting, but I think they have to look out here. Okay. Hopefully that makes sense what I'm saying. Okay. So what's the treatment paradigm for upfront wild type metastatic colorectal cancer? So obviously you need to check their mismatch repair status. If they are deficient or MSI high, they go on immunotherapy. If they're stable, you need to check their BRAF status. They go on to EGFR inhibition and BRAF inhibition. And then if they're wild type, if they're right-sided, they go on to bevacizumab with chemotherapy. If they're left-sided, based on this study, they go on to panitumumab and FOLFOX. And again, the challenges there are this. And again, you're going to have patients that are getting oxaliplatin neuropathy, that are having this rash, and that are having a pump. Some people are going to try to substitute capecitabine into this regimen. That's going to make things even worse because there's skin reactions and certainly hand, foot. So again, it's going to be interesting how this plays out. This is the quality of life measure from 80405. And again, the quality of life in terms of skin, as expected, decreased. So this is all important in terms of how we consider changing first-line therapy, especially in the United States. All right, so let's leave that. What else was presented in oral abstracts at ASCO was a lot of EGFR inhibition. And again, I made the comment that a lot of the presenters were European. There weren't a lot of oral presentations from US investigators, but these are some of the other considerations or oral abstracts. So the IMPROVE study looked at intermittent versus continuous panitumumab for first-line therapy, kind of an Optimox approach. This was another strategic, which I'll show you in a second. This is how I practice, and it shows multi-line approaches. And then finally, the triplet was a study looking at FOLFOXIRI, which is kind of the kitchen sink approach using all our chemotherapy, and again, in combination with EGFR inhibition. So this is strategic, unresectable patients, wild type, RAS and BRAF, okay? And this was the trial design. So you were randomized to FOLFIRI, cetuximab, and then converted over to FOLFOX bevacizumab. Okay, and again, this is a European study. They like to use irinotecan up front. Versus what we tend to do here in the US, oxaliplatin-based therapy, bevacizumab. We will do some maintenance therapy while the patient's developing that neuropathy. And then FOLFIRI bevacizumab. So again, treatment beyond first progression, and then going on anti-EGFR therapy. We learned this very long ago with the BOND trials that anti-EGFR therapy can reverse the resistance to irinotecan. So this is kind of our approach, and this is a European, more of a European approach. I don't know if this is true anymore. I'm an older man now, and I think maybe some of their younger providers are using this more so in the US. But anyway, so the disease control rate was the same, early hazard ratio 0.97, so no real difference. But over here, there was a from the European approach here in the blue curve. 1.26 wasn't close to being statistically significant, but if you just do the numbers down here, 37.8, 34.4, about a 3.4 month difference, which was the same difference that we saw in the panitumumab trial, then there does seem to be some value in using this approach. And again, I think it has something to do with what you're doing in the second line. This is a very good regimen. This is also a good regimen, regardless. Okay. What else did they show was this intermittent versus continuous. This is kind of optimoxing. We used to optimox with pulling the oxaliplatin out, and because of the neuropathy. This is with FOLFIRI. This is the basis, I think, of a very good clinical trial, research trial that will be coming forward. But here's the study, FOLFIRI panitumumab, and then patients go on a second-line therapy versus FOLFIRI panitumumab and then treatment-free interval or maintenance therapy with pulse treatments of up to 8 cycles and continue until progression. In the study, the patients got about the same treatment, 13 cycles per patient. Discontinuations were higher in the continuous arm versus the intermittent. And again, there was a lesser adverse event reason for discontinuing 17 versus 4. Okay, skin toxicity was higher in the continuous versus intermittent, which gets back to what I was saying. This is one of the challenges that patients face on a daily basis, managing that skin toxicity, and using this intermittent approach may be very helpful. The other interesting, and then this is just their survival, or I'm sorry, the PFS 20 versus 13, and they were looking at that 12-month mark. So very interesting trial. The other reason that this is interesting was, I believe it was last year's ASCO. We all know that one of the mechanisms for resistance to EGFR inhibition is the development of RAS mutated clones. They appear, and there was data to show that if you pull the EGFR inhibitor out of the treatment and continue with irinotecan only, you were able to reset the proportion of wild type sensitive clones. So this approach, especially if you're going to do ctDNA, which we heard about earlier, may be a really good approach, and you don't have the cumulative toxicity of oxaliplatin. And so this way you can keep patients on treatment longer and perhaps extend that survival even further. So that's an interesting research study that's ongoing. All right. So then finally, the FOLFOXIRI kitchen sink approach with panitumumab, and then FOLFIRI panitumumab. I'm sorry, FOLFOX panitumumab. This was the trial design. And at the end of the day, they did have high responses. A good number of patients, almost 30%, went on to surgery. This is especially as effective in left-sided patients. There was no real improvement, though, with the addition of the irinotecan to FOLFOX. So you probably can get by with FOLFOX panitumumab, as shown in the first trial that we talked about that was a plenary session. All right, so let's leave metastatic colon cancer and then keep moving on. I don't have a timer. Are we okay? Someone's got to alert me at some point.
You're okay.
Yeah. Okay. I'm probably going too fast. All right. So this is really kind of neat data. It's early data, but it's really interesting, and it may change how we not only treat rectal cancer but also colon cancer. So PD-1 blockade in as curative intent in mismatch repair deficient locally advanced rectal cancer. Okay. So obviously we're treating patients, and I'll show you this in a minute. We treat patients in 2022 with chemotherapy, radiation up front, and then we have the patients go on to surgery. Some patients are not eligible for surgery. There's the potential for lifelong ostomy, other issues with their bladder, sexual function, bowel function. But if we look at rectal cancers, about 5 to 10% of them are mismatch repair deficient, and they can be resistant to chemotherapy. But we know that their high response rates is high, and especially pathologic response rates, complete responses. So can we get rid of these components of treatment that we now employ, which again can lead to long-term consequences? So this is the drug, PD-1 inhibitor, and they use this given every 3 weeks for 6 months. And then they evaluated the patients. If there was residual disease, patients went on the chemoradiation as you would normally, and then surgery as considered. So this was both stage 2 and stage 3 patients. This is a single institution study. This was done up in New York, small numbers of patients. Okay, their primary objectives, response rate, and then path CR, as well as clinical complete response, okay, and safety and tolerability. Okay, so how do you look at the clinical response? Well, they did rectal MRI or endoscopic evaluations, and these are criteria for clinical complete response: disappearance of the tumor, normal digital rectal examination, and then the MRI, lack of signal in lymph nodes that had reduced down to 0.5, that may be just reactive, okay? And these are the demographics. Really not a lot to say. T3, T4, a large number of patients, node positive, a large number of the patients. Okay, again, these numbers are in the teens. There were germline mutation patients seen here. Okay, tumor mutational burden was also elevated. Okay, all right. So this is the first patient, 38-year-old. He's now been followed for 23, 24 months. He had T4N0 or N plus disease, and he achieved a clinical complete response. So here is his tumor at baseline. And this is so remarkable. There's a little bit of a scar there, but really, really quite remarkable follow-up out at 22 months. This is the MRI. This is the cancer, this thickened dark area that is reduced very nicely here and here. And then obviously the PET scan also showing lack of activity. So this is pretty impressive. I'm sure the investigators were pretty stoked when that happened. And when they look at all the patients here, I believe there are 14 patients. The survival, the follow-up is only about, for only 4 patients beyond the 20 months. But even so, they saw complete clinical response in 100% of the patients. Okay, so that's very, very impressive, both by examination, endoscopy, and also by MRI. So very impressive data. And then you look at, this is again, was the treatment over about 6 months. And if you look at these lines, wow, this is impressive. Median follow is only 6.8, but even so, there's these 4 or 5 patients that are well out beyond 20 months, and there are patients right behind them. Okay, again, clinical complete response, pretty impressive. So key observations, 100% and 14 patients they evaluated. Really no major unexpected side effects. Patients did not require chemotherapy, radiation, or surgery. Disease recurrence needs to continue to be followed. Okay, so this was a late breaking abstract. Does this form the framework for immunoablative tumors or therapies? Highlights biomarker driven, especially in the mismatch repair patients. But this is interesting when you think about, this is Kimi Eng's discussion. This is interesting because it potentially resets the paradigm in how we treat our patients with locally advanced rectal cancer. So typically this is what we do: give the chemotherapy, radiation, and then take the patient on to surgery and give postoperative chemotherapy. We are more and more adopting total neoadjuvant therapy. This is for low rectal cancers that the tumor is invading the sphincter and the patient is at risk for lifelong ostomy and lack of function, lack of continence. So we're more and more in those lower rectal patients giving chemotherapy for up to 8 cycles, 4 months, and then having them go on to chemoradiation and then surgery. But is there the possibility that we can get rid of the radiation in total, especially for the upper and mid rectal tumors? And again, when we consider the rectum, it's from the anal verge up to 12 to 15 centimeters. So that's what we're dividing into thirds. Okay. This is the prospect trial. This is ongoing, seeing whether or not in those upper and mid rectal patients and maybe some of the lower rectal patients, whether we can get rid of radiation. And then can we get rid of surgery? This is the data from Oprah or from the MSK people of whether we can watch and wait. Okay. But now with this data, can we get rid of all of these interventions? And that's what they've done in the first 14 patients. Quite remarkable. Now, this is what I just said, the watch and wait approach. So I was not aware of this, or I wasn't as aware of this, but we know that in metastatic patients, we get good responses. So Ipi-Nivo, 70% here, second line Ipi-Nivo, 55. So we get very good responses. And then looking at early stage patients, obviously defective mismatch repair, you can get as high as a 95% pathologic response rate. And then I didn't know this, proficient mismatch repair patients. Okay. So again, proficient, locally advanced, they also have good responses. So 20% major response, 13% pathologic complete response. So what's shown here, this is with Ipi-Nivo. In these green bars, those are the proficient mismatch repair patients. Wow. So that potentially, and there are trials ongoing with chemotherapy, but we're not studying, they're excluding the proficient, but that's very interesting. So at the end of the day, does this make sense? Checkpoint blockade may be effective in general in early stage colon cancer. We know there is a higher T cell infiltration. So we know those T cells hang around in the lymph nodes, and that's how they wall off the tumor. There may be less systemic immunosuppression. Neoadjuvant checkpoint leads to high rates of path CRs in other diseases. Okay. And there is this trial, the niche trial, and they did see some responses in proficient. And then here's some of the science behind this. There's more neoantigen specific T cell clones, increases the tertiary lymphoid structures. Okay, so very interesting data, and I think a lot to come. Hopefully we can present some impressive data for early stage rectal and maybe even colon, defective mismatch repair, MSI high, yes, and maybe even proficient. So exciting. All right, so as a randomized trial, yes, we need to validate this 14 patients. I don't think we need to do this whole trial, but I think we just need to, if it's really that 100% clinical response and it's meaningful and durable, then we don't need to do a trial. Okay, so let's move on. Those were the two late-breaking abstracts and kind of what was seen up front. I'm going to go through two more colorectal trials and then get out of the colon. This was a trial that we tried to do through the US Intergroup probably 10 years ago. Me and George Chang from MD Anderson proposed this trial of doing perioperative chemotherapy in patients with high-risk tumor. This is Dr. Deng, who I've worked with. She's out here at this Yatsen University Hospital. These hospitals are huge. There are 9 buildings each, and they can do their own phase 3 trials in and of themselves. I'm going to go through this quickly, but what you need to do this study is advances in radiology. You need to do a CAT scan that can accurately depict T3 and T4 lesions. So the key eligibility here was that they could do that, and they could actually see through the wall. Yeah, we can't do that. You know, the depth of invasion. So in the trial, obviously they gave neoadjuvant chemotherapy, then surgery, then additional chemotherapy about 7 months. And in the standard control arm, they gave just surgery. I'm going to go through this very quickly. Again, the radiologic assessment using just CAT scans. So I want you to just focus on these numbers. 80% were T4 according to their radiographic assessment. 80% were lymph node positive. So somewhere in that ballpark. And then let's jump to what they did at the time of resection. N0 was now 69 and 54. So they were not accurate in terms of their prediction of lymph nodes. And then in terms of T4, they were way off. So 10%, 20%. There was a downstaging, as you would expect, perhaps. But at the end of the day, you can't really do this. Certainly, if you have a patient with a T4 lesion and tumors extending to the wall, or you're concerned about invasion in other structures, you may give chemotherapy up front. But we really can't do this in real time, and they couldn't either. They do seem to suggest that there's a benefit, but I'm not sure that's true. Okay, this is the other study that I thought was interesting. Again, another oral presentation. This comes up in clinic all the time. Patients with metastatic disease, do you take the primary out or not? Why do you take the primary out? To prevent complications, avoid emergency surgery, and the prognosis may be improved. Why don't you take it out? Overall survival is determined by not the primary, but the metastases. If the patient's not symptomatic, bleeding, or obstructed, then why take it out? Why delay and have the risk of surgical complications? So this is a question that we ask all the time in the clinic. This is a randomization, primary tumor resection and chemotherapy versus chemotherapy alone. Again, these are all metastatic patients. And at the end of the day, this is a result. The number of patients that got chemotherapy alone and that at some point required resection was only 3%. Okay. And obviously the patients that went on to resection, 90% of them went on to resection. Okay. So this helps validate how I practice. I don't take the primary out unless they're bleeding or they're obstructed or they're having a lot of pain because it does delay our chemotherapy administration. These are the survival curves shown here, 18.6 with the chemotherapy alone versus taking time to do the surgery and then 16.7. So again, validating what we do. All right, let's move on. I know we heard from Tara before this presentation, but this is an interesting study looking at circulating tumor DNA. It's a stage 2, really should be a stage 3. It's a dynamic trial, and also investigators over at Hopkins up the road from here. And we know this, that circulating, we just heard this, if you're negative, you have a better prognosis than if you're positive in the postoperative setting, clinical low risk, clinical high risk. And then in stage 3, this is really where we need to see the impact and how this may guide our treatment decisions. Again, this is all prognostic at this point, not predictive. So stage 2 cancer, surgery cures about 80%, although about 25% of them will be treated. And this is mainly in the high-risk patients, which we'll define in a minute. And recurrence is still a risk. So ctDNA can detect minimal residual disease. I think we know that pretty well at this point. And this was trying to use ctDNA to guide how to do your treatment. So this is the trial stage 2 patients. Randomization 2-to-1. Now you had to get your blood collected at 4 and 7. And I asked Dr. Todd why that was important. I guess they're trying to make sure that these clones are persistent in the blood. But here's the ctDNA positive patients went on adjuvant therapy, ctDNA negative were observation. Now, what I didn't show you is that these numbers are very small, and I've criticized these evaluations. So you have a lot of patients that are negative. You have a small number of patients that are positive, okay? And it's upwards of about only 25, and same thing over here, about 25% of the patients are positive. So it's not a lot of patients. And the comparator arm in this analysis was standard treatment. And I tried to understand what this was, and I think I figured it out this morning. So relapse-free survival at 2 years. This is how the tissue was analyzed. They did have to have the original tissue. They used these mutated genes, which are very common in colon cancer. Again, weeks 4 and 7. And this was specific to the patient, the safe sequencing system, again, developed by the Kinsler-Vogelstein group up at Hopkins. Primary endpoint, patients were randomized, had both blood draws. And then here's it's important to look at, minus 8.5 was a non-inferiority lower bound, okay? So just keep that number in mind. In terms of baseline characteristics, not a lot to say here. A lot of the patients were T3, not T4. Obviously, they were all lymph node negative, but there were risk factors seen here, high clinical risk, low lymph node yield, lymphovascular invasion, and then a small number of MMR proficient. About 40% in both arms were what they consider clinical high risk. In terms of adjuvant therapy, about 15% versus 28% in the standard arm. So ctDNA did lead to a lower number of patients getting treated, a lower number of oxaliplatin treatment, which is interesting, or I'm sorry, a higher number of oxaliplatin treatment. Then the duration was about the same, okay? And so this is really the take-home message. For example, if you have a T4 lesion in the standard treatment arm, most of those patients, upwards of 70%, are going to be treated. If you have ctDNA guidance, a fewer percentage of those patients are going to be treated. And this is out here favoring less chemo with the ctDNA approach. So this is really the take-home message here. That, yeah, it does help you make a decision. Now, presumably these were T4 lesions with negative ctDNA levels. So, and again, very small numbers, okay? They don't give us specifics, but these are small numbers, okay? Same thing with the lymph node yield, or opposite thing with this less than 12, okay? But poor differentiation, lymphovascular invasion. So again, this did help in some regard the decision to give less chemotherapy when one considered the high-risk patients. More standard arm patients got, or standard approach patients got chemotherapy versus patients that had been informed by ctDNA, presumably negative ctDNAs, because that's a higher percentage anyway, and those patients did not receive chemotherapy, okay? All right, so that's the take home. And then recurrence-free survival was not different with either approach. And again, their non-inferiority lower bound was minus 8.5%, and they reached minus 4.1%. So this is a viable approach, is I think the summary. Recurrence-free survival, pretty much, because there was no difference. They're all going to be at 1. And then again, what we've seen over and over again, negative ctDNA patients do better than positive patients. And again, these are all stage 2. And then ctDNA and clinical risk, and ctDNA and T stage, okay? So we've seen this before. And again, my criticism is these low numbers that are positive, okay? 45, all right. All right, so that's that. Let's move on. Let's talk about pancreatic cancer really quickly. Again, radiation continues to be considered. This is the CONCO 7 trial, European, French, I'm sorry, German. And this is the study design, dealer's choice chemotherapy, restaging, making sure there's no progression, and then randomization to chemotherapy radiation. Gemcitabine is being used here versus additional chemotherapy. So they're still asking this question of whether radiation is needed. Their primary endpoint was remarkably resection rate. So again, these are locally advanced patients. These aren't borderline patients. These are locally advanced, which means they have arterial encasement and their primary resection rate. Okay, and so about 60 patients in both arms went on to surgery. The PCR rate was quite low. The R0 resection rate, I think in this group was high. Again, they selected out patients. The circumferential margin was also higher in the chemoradiation. So bottom line here is there was an improvement in R0 resection. There was an improvement in clearing the retroperitoneal margin, which is the most difficult margin to clear. And that was meaningful here. Okay, but again, small numbers of patients at the end of the day. Overall, all the patients that were randomized, the resection rate was about 30%. I would argue this is a little bit high. We don't see that here in the United States. We see that in the teens typically. But again, the primary endpoint was resection. And then at the end of the day, there really was no difference in terms of PFS or overall survival. Okay. And then obviously, if you had a clear circumferential margin, or if you had a R0 resection, you did better. Okay. So at the end of the day, it's an important trial. There's no difference. But in select patients, I think they do benefit. These are very high resection rates. And does it mean that we should take all patients to surgery that have locally advanced disease? I have a problem with that. I think a lot of people do, subjecting a patient to a major surgery, a Whipple procedure, and yet they're not clearing the margin, not clearing the cancer with an R0 resection. Okay. All right. Home stretch, gastric cancer. This is the umbrella trial. This is done by the Koreans, looking at second-line therapy. This was unique. Again, this is an oral presentation. We know that in the second line, we used Taxol plus or minus ramucirumab, anti-VEGF therapy. Anti-HER2 therapy is the only treatment for which we have targeted approaches. So could we do a trial with a control group using the standard paclitaxel plus or minus ramucirumab, and then a bucket approach? So EGFR inhibition with afatinib, PI3 kinase, Nivo, and obviously the MSI patients, or no biomarker. And so at the end of the day, I thought this was neat. They in terms of progression-free survival, and then in terms of overall survival, there was no difference. So this is an approach emerging in gastric cancer. The buckets, I think, still have to be defined, but this was a good effort, and we'll have to see how this plays out. And then this is the specific markers. Obviously, the checkpoint inhibitor patients do the best, and then they do some do worse than the control arm. Okay. So we know that in esophagus cancer, GE junction cancer, if you give chemotherapy radiation followed by checkpoint inhibition for up to a year, there's a significant improvement in survival. So this analysis now is looking at perioperative atezolizumab, or a perioperative approach with flat chemotherapy in esophagogastric patients. Okay. So flat is the standard, but can we do this with a PD-1, PD-L1 inhibition, in this case, using atezolizumab? This is a very straightforward trial design. This is your control arm. This is the atezo-containing arm. Primary endpoint was the dual PFS, DFS, and then looking at responses. And at the end of the day, these are the patient characteristics. And important here, most of the patients were greater than 1, but there was a group of patients that was less than 1. This is also what we saw in the esophagus data, that patients with CPS of less than 1 actually can benefit. Obviously, the patients that have higher levels will benefit as well. And so with the treatment, you do see this reduction in terms of the lymph node positivity and also the staging. So atezo does seem to provide some benefit, especially in terms of the T stage, questionably in terms of the lymph node. I think I said that backward. The lymph nodes doesn't seem to affect, but in terms of T staging, there may be some down staging here. Okay. In terms of pathologic response, this is seen here, the atezo arm higher than the non-atezo chemotherapy only arm, okay? And again, the benefit is seen in all the CPS groups. All right, so is this feasible? The answer is yes. We have to look at the survival data, but this is a reasonable approach. All right, last two abstracts. So FGFR inhibition in bile duct cancers, this is becoming more and more available for our patients, especially with the intrahepatic cholangio patients. This is all the background chemotherapy is what we typically use, Gemcis, Folfox, and then we know that up to 40 to 50% of particularly intrahepatic cholangiocarcinoma patients harbor these mutations. And so this is the drug that was being tested, futibatinib, and it targets all of the FGFR receptors. It's also active in other cancers. So the trial was using 20 milligrams to disease progression. These were the actual aberrations, so mainly fusions and rearrangements. And this is the waterfall plot, and again, showing that many patients responded with tumor reduction of greater than 30%, response rate 43%, so almost half the patients responded. The duration of response, again, if we look beyond 6 months or even 12 months, a good percentage of patients. So the median duration of response is right around 10 months. And then the overall survival is 20 months, okay? In terms of toxicity, really this hyperphosphatemia, which is a class effect, this is well managed. There is some fatigue, mouth sores, hand, foot. So at the end of the day, this is another FGFR receptor that is available with high responses. And I know we're not supposed to compare across trial, but if we do look at this, response rates are highest with this agent. Control rates are about the same. Median durations 9 months, and then down here in survival about 20 months with this latest FGFR2 inhibitor. Okay. All right, last one. This is the American ECOG neuroendocrine tumor. We don't talk a lot about neuroendocrine tumors, or I haven't in the past, because they are slow-growing tumors, but this is an important study, I think, that helps validate how we practice again. This is a randomized trial of temozolomide versus temozolomide capecitabine, the CAPE-TEM regimen, and they're looking at MGM2 as a predictive marker. Okay, so back in the day, temozolomide was considered a standard. I've not really used that. I came from Mayo. We used streptozotocin, dacarbazine, 5-FU, some really aggressive regimens back in the day. We know that MGM2 does, or I'm sorry, MGMT helps regulate temozolomide. Lower levels lead to sensitivity, higher levels resistance, and can this be a biomarker? Okay, so here's the clinical design, the CAPE-TEM regimen versus TEM alone, progressive low and intermediate pancreas neuroendocrine tumors. PFS is the primary endpoint because these patients do so well. They had to have prior treatments, or some of the patients had prior treatments, and they also had to have somatostatin analogs. I'll just show you about 50% of patients were on those treatments. And again, grade 1 and grade 2, a higher number in the control arm versus the experimental arm. It met the primary endpoint here in the yellow. CAPE-TEM was superior, 22.7 versus 14.4. Statistically significant, okay? But look at these survivals. This is PFS. These are quite long, which is characteristic of this tumor. And then in terms of overall survival, we're still waiting for the data, okay? But again, I consider CAPE-TEM the standard regimen in these patients. Response rate, very respectable, okay? All right, MGM2 deficiency correlated with outcome, and that's shown here. So if you are low, then you do have a higher response. Okay, as expected. All right, I think that's it. Yeah, and then there's a tendency for here in this dotted yellow line in terms of PFS, but remember the overall survival has not been reached, so there does seem to be a benefit in these low MTM patients, deficient MTM patients. Okay, all right, that's it. Okay, so colorectal cancer in 2022, EGFR inhibition of left-sided colon cancer is a standard. Again, you have to explain to the patient the rash, the neuropathy, the pump can be cumbersome. If the patient asks you what is the best treatment, I think you're going to have to present that panitumumab plus FOLFOX is probably the best treatment, definitely in left-sided colon cancers. The rectal cancer paradigm is changing. Obviously, with checkpoint inhibition, we're potentially going to remove radiation, possibly surgery, and probably chemotherapy. ctDNA is useful in adjuvant therapy, but we need to be able to use it as more of a predictive marker. Do we get 3 months of chemotherapy or 6 months of chemotherapy? Can that help? Pancreatic cancer, we talked about the impact of radiation, and then bile duct and neuroendocrine. Okay, so you want to do the questions real quick? Yeah, I know we don't have an audience response, but okay, so metastatic, obviously the answer is left-sided. I know my presentation was so good that you all know this now. And then which treatment paradigm will change? Again, I just said radiation, chemotherapy, surgery, all potentially will change. Again, there's the possibility for lifelong ostomy, bladder dysfunction, reproductive organ dysfunction, bowel dysfunction. We can eliminate this. And it's not only in the deficient mismatch repair MSI high patients, there may be a component of proficient patients, local advanced, that can benefit. That I think is really provocative. They're really cool. Okay, FGFR inhibitions, obviously futibatinib, I think that's the right pronunciation, is the answer. Okay, with that, I thank you. And again, thank you so much for inviting me. I know the College World Series starts next week. At sometime in the future, I hope to be out there in the stands. I have a little trophy of a foul ball that I got. I should have put that in this system or in the slide deck. Also, I didn't have time to put the kids in there. The kids graduated from high school. I got some beautiful pictures. Maybe I'll show them next year. They're going to Florida State and Florida, so they did pretty well. Dad's going to save a heck of a lot of money, so that'll be interesting. But again, thank you so much. And this conference and Dr. Townley have been a part of my family for many, many years. So thank you. Thank you for letting me participate.
Thank you so much, Dr. Kim. And with that, I want to open it up to any questions from the audience. Remember, you can either put those in the chat box or unmute yourself. And we do have a question in the chat box. Dr. Kim, anything at ASCO about MCRC in young adults, incidence, prognosis, therapy in general?
Yeah, there was nothing. Again, I covered mainly the plenary and oral presentations. There is nothing. I mean, there were some posters, definitely, but there was nothing really specific to that. I will tell you in that analysis from MSK in the checkpoint inhibitor in the locally advanced rectal, there were some young patients in there. And so it does seem that they do benefit. And that's going to be incredibly important when you think about lifelong consequences of our therapies, both surgery and radiation. So I think that's interesting, very interesting. And they do tend to be, mismatch repair patients do tend to be younger, obviously. They're diagnosed by age 50 in general. So hopefully that will benefit them. But in terms of younger patients, the answer to your question is not a lot.
So George, on Monday, when you see a young person with rectal cancer that has Lynch syndrome, what are you going to do for that person?
Yeah, that's a great question. And they've probably heard about this on the news. I think you got to go with the standard at this point. It's 14 patients. Only 4 or 5 of them were followed more than 20 months. Most of them were less than 10 months. So I think you still have to go with the standard. If the patient says, I want this approach, you're going to have to find a drug that'll get approved. And then I would perform close surveillance. I mean, that's again, the watch and wait, especially if they respond. Okay. Now, if they respond, you want to keep an eye on them, much like in the trial. But if they don't respond, then, and they're a young patient, then what are you going to say? So yeah, it's really exciting data. But I don't know if I would really employ it at this time. I would definitely talk to the patient. If that's what they wanted, then yeah, it would be great to use that approach.
Thank you.
Kind of a wimp.
All right. Do we have any other questions from the audience for Dr. Kim? All right. Dr. Kim, thank you so much for sharing your time with us this Saturday, and thank you for just sharing your expertise with us as well.
Thank you again, and thank you for putting up with all those slide iterations.
No problem.
All right, folks. We'll see you soon. Okay.
All right. Thank you.
Thank you.